times for today are approximate, and they may be affected by the technology. Please enter your questions using the Q&A feature at the bottom of your screen. This is a webinar, not just a Zoom discussion. We will have time for 1 or 2 live questions following the comments from each of our speakers, with an open Q&A period following Ms. Ana Castillo-Nye's comments at the end. If your question is not answered live, we will do so after the event and share that with our attendees. First, a bit about today's discussants and what they will be discussing. First, our welcome will come from Dean Roger Hartley, who is the Dean of the College of Public Affairs at the University of Baltimore. Our keynote for today is Dr. Christopher Gibbons, MD, M.P.H. He is a digital health innovator, an entrepreneur, a physician, and a scientist. His topic is achieving health equity, possibility or pipe dream. As an aside, but probably should be front and center, I should tell you I've known Dr. Gibbons for multiple decades, and he is someone I have great admiration for, and I'm looking forward to hearing him speak today. Following Dr. Gibbons, we will have Mr. Michael Brown, who is the Vice President of Hurdle. Hurdle is a company that's a startup. They've had VC funding. They're meeting a need for equity in the mental health sector. But as I spoke with Mr. Brown, he was explaining that they are now expanding beyond the initial cultural fit of persons with needs for mental health care and providers who can provide that care in a culturally appropriate way. And then we have Dr. Yahya Shaikh, who is a principal scientist for connected health systems at MITRE Corporation. He has previously worked with the Federal Communication Commission's Connect to Health Task Force in a variety of capacities, including exploring and engaging with a wide range of innovations, innovators, and the breadth of the startup ecosystem from funders to founders. Dr. Shaikh has worked with health startups in a variety of capacities as a co-founder and continues to advise them. His background includes guiding efforts for equitable information systems and fair analytics. And Ms. Ana Castillo-Nye is the Director, Organizational Development and Community Partnerships at the Lutherville Pharmacy. She serves as a liaison between the pharmacy and a number of community and small business organizations in the greater Baltimore area. Beyond the work that a pharmacy does in normal retail operations, Lutherville Pharmacy's core mission is to offer special services and develop strategic relationships meant to ease navigation through a complicated healthcare system. They are always open to creative and philanthropic partnerships with a special focus on HIV patient care. And Ms. Castillo-Nye is currently a doctoral student at the University of Baltimore's Doctor of Public Administration program and considering the focus of her research to be 340B drug pricing programs. As you'll see, there is a constellation of interest, accomplishments, and activities around removing inequities and expanding to underserved populations to the extent that startups and innovation, that business development can do that. It can happen, we think, faster than the legislative solutions for which we should continue to work. And now, it is my honor to introduce the Dean of the College of Public Affairs at the University of Baltimore, Dr. Roger Hartley.
Alan, thank you so very much. Students, faculty, staff, and friends all over the globe, it's my greatest pleasure to welcome you to this year's Rosenberg Dialogues. And I wanted to begin by extending wishes from our president, Kurt Schmoke, who could not be with us here today. I wanted to begin by giving some thank yous, and I wanted to start with our incredible organizer of this panel today, Dr. Alan Lyles. Alan Lyles serves in the College of Public Affairs at the University of Baltimore's School of Health and Human Services. He is designated due to the generous support of the Blaustein Foundation, our Rosenberg Professor But Alan Lyles is a magnificent teacher, magnificent researcher, and a magnificent public servant as well. I like to brag on you, Alan, whenever I get a chance, and sometimes you don't know it, but I'm going to do it here publicly. Alan is a member of the National Academy of Public Administration, which is one of the most elite and important associations for honoring the work of public administrators and scholars. And I also like to mention Alan is one of seven faculty members in the College of Public Affairs that have earned the University of Maryland's University Systems Board of Regents Award. And his award was for his incredible work in scholarship. Alan, your dedication to the creation of and the long ongoing series, our Rosenberg Dialogues, is so very appreciated. And I also, in any event like this, I want to say a few thank yous to people behind the scenes who make this work. I really appreciate Jared from OTS, who has helped us put this webinar on today, Ms. Cynthia Opakunle in the College of Public Affairs for all of her assistance in helping you, Alan, organize panelists and put this together, and certainly Monica Queen and many others who have helped promote this event today. A little bit about the College of Public Affairs. The College of Public Affairs is made up of 3 marvelous schools and 2 centers that are completely dedicated to public service, but also to improving lives. We do that work through our students, through our teaching, research, and service. Alan, of course, is part of our School of Health and Human Services, which is led by Professor Tina DeFranco, who is an amazing leader. And we have 2 other schools, our School of Public and International Affairs, as well as our School of Criminal Justice. I wanted to say, too, that this very series today, our dialogues on the issue, very important issue of health inequities, is so very, very important. And I wanted to recognize our work in this field in several places. Our School of Health and Human Services in degree programs like master's and undergrad in health administration and management, also our degrees in human services administration. But we have an incredible center called the Center for Drug Policy and Prevention. And there's a relatively new division that you should watch out for, which is called a Division on Addiction Prevention and Treatment inside of that center, which focuses completely on providing technical assistance, research, and additional effort all around the nation for localities who are battling the drug abuse problem and addiction problem, and across public agencies, which is really hard. Most of the work that we see done in healthcare and in all facets of public administration and policy is often done in silos, and those collaborative efforts are hard to make, hard to create, but when they are created, they really work. And finally, our Shaffer Center for Public Policy, who has done study after study with the Maryland Department of Public Health and other agencies to help us eradicate and provide more information and research on fields such as smoking cessation, as many others. On this particular topic today, and I'll keep it a little bit shorter, this dialogue on healthcare inequities and especially entrepreneurship, I was struck by its importance, Alan, and to our guests who are with us here today. You're absolutely right, Alan, in that many of the great solutions that have occurred in healthcare through government, through the public sector, have been slow, sometimes deliberate, sometimes not deliberate, and in the case now, really hampered by political division. And that is such an important point to talk about here today. One of the biggest issues that comes up, of course, now is where do those solutions come from? And I'm really eager to hear from our speakers today about the efforts through the private sector, through entrepreneurship, also efforts that come from nonprofits, which also creates change in public policy and in work. But also I like to say universities, the research, the dialogue, the pushing of ideas and boundaries coming from a university or any university where dialogues like these happen and lead and inspire others to act. The pandemic, absolutely, Alan, the pandemic exposed inequities in healthcare and expose them, but they've been around for a very, very, very long time and have been persistent. Access to not just treatment, but testing, access to insurance is only one tiny little tip of the iceberg, to be quite honest. Insurance is critically important, but some of the access issues in healthcare and the inequities are things like time, economics, society, education, and a variety of other limiting factors that make it a lot easier for someone from wealth and privilege to be able to take the time out of their day to go all the way across town after months of waiting for a healthcare appointment to get that necessarily needed test, versus someone who's balancing family, children, work, that might have to get on a bus in a city that takes them 2 hours to get across town, which is only 5 miles. That kind of barrier in broader society limits access to healthcare, creates inequities, and is really a critical subject, regardless of whether anyone here would, or anyone here in this nation would provide perfect insurance. Those inequities still make it more difficult for people to reach care. What I'm really pleased about, and I only see as a citizen and a patient myself, is that the pandemic gave us more access to healthcare in some ways, maybe imperfect, but through Zoom and through other digital formats. The pandemic exposed the need, and we've been doing this for many, many years, for the opportunity to home test. These are situations where I think we have and have seen entrepreneurship and the need to serve change the way we serve, and have helped deaden some of these inequities. With that, I want to again welcome everyone on behalf of the University of Baltimore, the College of Public Affairs, and I want to turn it over now to our keynote speaker. We are so delighted to have you with us today, Mr. Chris Gibbons. Thank you for joining us.
Thank you very much, Dean. As I begin, if you would please put my slides up for me. But as they're doing that, let me say I am so impressed by this day that they've pulled together, the cast of people that would be speaking, and most with the comments of the dean that we just heard. He's absolutely right in pretty much everything that he said. These are big, complicated problems, but everybody has a role today to play. But today, hopefully, we can push your mind a little bit and get you thinking about actually achieving health equity, not just describing it, not just talking about it, not just being angry about it, but actually achieving it, what it looks like. Is it really a possibility, or is it just a figment of our imagination? Next slide, please. So just a little bit of the agenda, where we're going to go today. I'm going to talk a little bit about what we know, what science has taught us, but because most of us are very familiar, as the dean has said, I'm not going to spend a lot of time there. I'm going to give you the Cliff Notes version of that, and then move quickly to, so if we were going to be successful, what is required? And then if we were to get there, what would it look like? And talk a little bit about what we're doing in this space, and create a bit of a vision. The other speakers will talk about some of the major challenges that are involved in getting there. One in particular that you'll hear about that's extremely important, and others about doing work on the ground. So I think it's a lovely complement to the whole day. Next slide, please. So what do we know? As the picture of these pyramids implies, and your dean has rightly said, disparities and inequities in healthcare are not new by any means necessary. They have been described as far back as biblical antiquity, in the time of the Egyptians and Babylonians and others. And even in scientific writing, we have documented issues related to disparities as almost 400 years ago. I'm not going to describe it. I could tick to you the major occurrences, but the bottom line is they've been around for a long time, probably as long as we've been on this earth, and we've known about them, not just in America, but in other continents as well for a very long time. Next slide, please. So what do we know? Again, tons and tons of not only research, academic research, but also programs that have been implemented by nonprofits and for-profits and governments, state governments, insurance agencies, and a lot of policies. So what some people don't recognize, but especially when you take a global perspective and look at Europe per se, Britain in particular, Britain has acknowledged the UK has acknowledged these disparities far longer than the United States has done, and in fact, at the federal level, embraced a national, 2 different times set of programs to try to address these issues, and then came back 20 years later after that to measure the impact of what they have done, the policies that they've done at a national level, not just at a local or state or regional level. And so let me just make the picture here. They've known about them and admitted them much longer than we have. They've embraced them and tried to spend real effort, both at local levels, regional levels, and national levels, addressing these issues, and then come back 20 years or more after the fact, specifically to measure if what they did at a national level plus the other levels has made a difference. And the answers that have been reported in both cases is absolutely no difference. In fact, many of these things were getting worse. So we have tons of research, tons of programs, tons of policies at all kinds of levels that have been tried in this country and in other countries. And so in some sense, more work is needed because they're not fixed yet. But in other senses, there's a whole lot we know because we've had a great experience. Next slide, please. So what we know, nothing has worked. Nothing has systematically worked over time to reduce or eliminate and sustain that elimination of a disparity, particularly at scale, at a national level. There have been many smaller studies, demonstration projects, pilots, theoretical work, academic work that shows promise and improvement on smaller scale. But for those that have been tried to scale up, they either have shown disappointing results or have been far, 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 far too costly to make them economically viable and sustainable. That's the Cliff Notes version. We can talk about it more if you want specific details. I can talk about those. But at the end of the day, that's the truth. Nothing has worked. So that brings us to the question, okay, if multiple nations and multiple people and bright people and lots of money have gone into these things and there's been no change, in fact, they're getting worse, can we really fix this at all? Is that a reality, or is that a pipe dream? And that's really where I want to spend the bulk of our time today. So next slide, please. So what's required for success if we're going to get there? And just like this picture implies, this assembly line on this factory line, you have the robots, they do exactly the same thing every time, and they do it exactly the same way, and you produce exactly the same car at the end of the line. And as we know, expecting that factory line to produce a different car than what it is would be ridiculous. It'd be insanity. And so one of the messages that I'm bringing today, it is insanity for us to continue doing what we've been doing and expect that a different result is going to come. It makes as little sense as expecting this factory line to produce an airplane or produce something else other than what it was done. As long, whatever we have been doing and whatever we're currently doing now, may be working on a small level and may have promise, but it has currently not yet been shown to work on a national level. So we got to avoid insanity. Don't think that by doing the same things we're doing now, we will achieve the result that we have not been able to achieve over hundreds of years. Next slide, please. So what else do we need for success? In my view, we need absolutely innovative thinking. Now, a lot of people use that term and throw it around, but let me just give you two quick definitions. There are actually more than one type of innovation. This is work done by the famed Christensen up at Harvard Business Review, Harvard Business School, sorry. He unfortunately died about 18 months ago, but his work is seminal in this area. He talks about two different kinds of innovation. One is sustaining innovation, and sustaining innovation can be very important, right? It is what automobile makers do to their cars each year to keep you coming back and buying that car. They put new enhancements in that car. They put new bells and whistles in those cars that weren't there before. Some of them have never been there before. And in fact, that drives more people to buy cars and drives you to switch out your car, not when it's dead, but because you like the new things. That's sustaining innovation. But the reality is at the end of the year, it's still a car. It was a car last year. It's a car today. It's going to be a car tomorrow. It's essentially four wheels and an engine that takes you from point A to point B. It's just got new bells and whistles, a few added functionalities. So this is not to downgrade sustaining innovation. It can be terribly important. It can mean the difference between being a market leader or a laggard. But at the end of the day, sustaining innovation doesn't change the basic underlying structure of what you're doing. There's another type of innovation called disruptive innovation and disruptive thinking. Again, many people throw that term around, but are using it incorrectly or don't really understand what it means. And in a nutshell, disruptive innovation and disruptive thinking is thinking that when it's implemented, the implications of that thinking, of that innovation, go far beyond what the individual first thought. In fact, they go so far beyond, you can't even predict it from the beginning. So all those people talking about, hey, I got this disruptive innovative app or this innovative program, disruptive innovative program, the mere fact that they're calling it, that means they don't understand. Because you cannot predict the full impact of where the thing might go if it's truly disruptive. It will have more impact on just what you intended it to. It'll in fact affect society. And the most important part of it that is often, many times we're looking for the new shiny thing, the new type of phone. But in fact, disruptive innovations are things that change the underlying mechanisms of how things work, the underlying business models, how people make money from things. That's what's actually disruptive. And then that leads to new types of industries and new types of things. Fitting a new digital tool on top of the same old revenue model is not dead. It might be sustaining and it might be innovative. It's not disruptive. And the reason disruptive innovation is so important is because if you look at society, it's disruptive innovation that has enabled us to make catalytic leaps forward in areas where others were not able to do. And so if that's what's required here, in my view, in our view, to overcome this problem of inequities and disparities. We've had them for hundreds and hundreds of years. We've not been able to figure it out. We need new thinking, not incremental thinking, not sustaining innovation, but really catalytic, disruptive innovation and disruptive thinking that will take us beyond what we've ever thought of before. Next slide, please. So what else is required for success? In our view, something that some people may disagree with, but digital technology, digital technologies are actually needed. And, you know, I can hear a lot of people saying, well, that's great, but my people need to eat and this kind of thing. But, and that's true. But let me ask you a question. Right now, we've got about 320 million people just in this country, adding a net person every second. And we've got about, in the case of healthcare, about 800,000 or 900,000 physicians and about 3.5 million nurses and about 6,000 hospitals and health centers. And so that's the core of our healthcare system. It's not, I know there are other allied health professionals and they are very important, but just focus on the core right now. Of those 900,000 physicians, about half of them, 450,000 or so, are primary care docs, the rest are specialists. So it's got about 400,000 primary care docs, 3.5 million nurses, and 6,000 hospitals. That's the bulk of the healthcare system that is now responsible for the care of 320 plus million people. Let me ask you, how are all those people going to get the care they need when they need it, not just when the office is open and not in an emergency room? How are all of them going to get the care they need when they need it in the way they need it if we don't rely more on technology? I've asked that question hundreds of times to hundreds of audiences, and I always get the same answer: blank stares. Because it's pretty obvious when you put it in that text. And I've said it to a group full of physicians, I've read it to people, consumers. It's the same thing. And I used to have to talk about this a bit, but the pandemic has made it eminently clear to most people now, right? It's not even a question I really have to discuss anymore. We're not going to meet the needs of everybody when they need it unless we rely on technology. But it's not just one type of technology. I believe it's a number. And I won't spend a lot of time on this, but I think there's 4 technologies you need to keep in mind. One is broadband. Broadband technology is the underlying infrastructure that enables all other technologies that are going to be needed in this world to work together. Without broadband, think about it like this. Without broadband, your iPhone would be nothing. It'd be a dumb phone. A smartphone is only smart because it can connect to the internet and then connect to everything else, right? So the thing that's truly disruptive is not the iPhone, it's the broadband, it's internet connectivity. And so we're thinking about things a little bit different. The other thing is AI. Artificial intelligence. I think you're going to hear a little bit more about this later. There's some challenges with it, but obviously it has tremendous potential for the future. I think the other thing is automation, whether it's robotic automation of one form or another. But these are some of the technologies. And then finally, Internet of Things. Some of you may have heard of Internet of Things. We don't have time to discuss all of these things today. But when you start thinking about these things, you can now put these things together in ways that will enable services and programs and things to happen to accomplish things that simply were never, ever even possible before. Next slide, please. So what else is needed? We believe more women and people of Black, Indigenous, and people of color entrepreneurs. Because there are a lot of reasons we could talk about why. I don't think I have to explain to this audience, but one of the primary reasons is that most of the people developing interventions for those who are underserved are not from underserved populations. And many of them don't have any significant experience or expertise with those populations. Therefore, the assumptions they make, whether they're designing a new technological tool or implementing a new program or a new policy, the assumptions that they inevitably must make may not be the ones that are most appropriate for those populations. And so in order to fix that problem, we, as I tell people, focus on African American populations is not something I read in a book. In case you couldn't tell, I grew up in a Black family. So I know a little something about it, but it's not just my experience, right? We need more people from those populations affected involved in the game of finding, designing, and delivering solutions in order for us to get there, to be successful. Next slide, please. So when we get there, what would it begin to look like? And this is where I have some thoughts and ideas that you may disagree or different. But in this future world where technology is deployed in the way that I think it can be deployed and achieved what we can, insurance companies will become health companies. So they're now not just about paying bills, they're actually there about helping you to be healthy. Retail stores, pharmacies, and post offices become health centers. I wrote these slides and used these for the first time probably 5 years ago, again, before the pandemic, Today, some of this stuff is happening and people see it. Back then, it said, well, what are you crazy? We do healthcare at hospitals and clinics. Why retail stores? You're crazy. But now nobody's surprised talking about getting healthcare at Minute Clinics or at CVS or Walgreens pharmacies. Your TV and any other screen will become your doctor's office. Think about it. Your TV and any other screen you had can become your doctor's office. Your smartphone or dumb phone, for that matter, will become a health device. Consumer technology, including clothes and apps, will assist you with health management. Patients will support each other through social media, VR, and AR. And those are in yellow because they are already happening. I'm not even talking about stuff in the future. It's already happening. The ones in white haven't yet happened, but I believe they will be happening, or people are working on them now. Doctors will not only treat you as a patient in front of them, they'll treat environments in which you live. Our medicines will tell us when they need to be taken, instead of relying us to figure out ways that we can take them and then document if we have. Your car will become your ambulance. No population will be hard to reach, because we can reach everybody one way or another almost today through technology. Healthcare becomes not a thing you get at a certain place, but it becomes embedded in life. And it's everywhere, and it's happening all the time. And your home will become your hospital if it needs to be, wherever you live. Next slide, please. So what does this health equity look like in terms of ending health disparities? Then if you begin to think like this, it's less about how do we fix this or that specific disease gap or determinant, and more about how do we create the opportunity for solutions to scale and spread like wildfire to every single person. And in this way, we believe we will be able to accomplish things that, frankly, were impossible to accomplish before. Next slide, please. So I can end up with just some examples. Let me give you one example and then cast a little vision for you. These are actual use cases that we have produced for clients to help them envision this future world. Imagine for a moment that you're living in this new world where technology is deployed in these ways that I'm talking about, and you have a son or a daughter, 5 or 6 years old, who has asthma. And asthma is a common disease, and more common among inner city and African American populations. So there's certainly disparities associated with it. And it kills. I have 2 childhood friends who had asthma and are dead now because they couldn't get to their inhalers fast enough to abort the system. But say tonight you're living in one of these homes, you tuck your little boy or girl in bed, and you wonder as a parent, I wonder if they're going to have an asthma attack tonight. Will I hear it from the room in which I live? Or the bedroom that I'm going to, or downstairs, to be able to rush in there and help them with their inhaler fast enough, because as a child, you have to help them. When they're adults, they can do it by themselves. Well, tonight is the night, in the middle of the night, your son or daughter begins to have increased work of breathing just before a frank asthma attack. But this time, they're located in this new house that I'm talking about. The house may not be new, it may or may not be new, but it has sensors and things embedded within it that the house detects this increased work of breathing within a fraction of a second. It then sends that information to the cloud, where it's analyzed in context with what's going on in your house, pollen levels, your medical history, determines that your medication profile, and determines that you're about to have an asthma attack. And in a fraction of a second, it sends 2 commands, not to your doctor, not to your nurse, not to you. It sends 2 commands back to your house. It sends one command to the room in which your little daughter is and says, raise the humidity level in that room. Well, why would it do that? Because when you're taking your inhaler or your nebulizer treatment, that's what you're getting, moist, humidified air. And the second command is out of those same vents, give 2 puffs of albuterol, which is the medicine that rides on the moist, humidified air. So in that moment, in a fraction of a second, your daughter's asthma attack is aborted before she even fully wakes up. You know nothing about it until the next morning you check your phone and you get get a note from your house indicating the healthcare that was administered. That's what's possible. And in fact, we're not far from that yet. There are people working on these kinds of things. I could give you some other examples, but for the sake of time, let's go to the next slide. If people want to ask or we have time, I can come back to those. But I don't want to assume that this is just about technology. We're going to need people. We're going to need people from the communities, not just to design solutions, but to help. These are a group of what we call community health navigators. They are all people from the inner city of Baltimore with very different backgrounds. This is the first set of 6 that I trained many, many years ago, and then employed as these, I don't have to explain the concept, but help to identify and work with people in the community to overcome challenges. We demonstrated at Johns Hopkins how valuable they are, and I'm proud to say that now that I'm gone from there, this program is still going on. But to give you an example, this lady in the front to the right, she was a retired federal worker. The gentleman standing behind him in the white hadn't finished high school. And the other gentleman in the back was about 57 years old, HIV positive, strung out on drugs for many, many, many years, in and out of jail many, many times. But I took these individuals, we trained them over a 6-week period. We trained them at a level that they could converse with doctors in the hospital. And a number of them came back to me beaming, saying, my doctor, I was talking to the doctor or a doctor to help with a patient, and they just stopped in the middle of the conversation and said, how did you learn to talk like this? I mean, this is phenomenal. How did you learn to talk like this? These are individuals from the street. These are people, some of which had good backgrounds in education, some of which had no backgrounds, but we proved it's possible within a relatively short period of time to get them to a level where they can do amazing things. And our goal was to equip them with technology so that they could bring the internet and the technology to people who didn't have it as one way as getting over this problem. Who's to say you need a 24/7 always on gigabit connection in order to benefit? That's not true. But if people can bring it to you, that might be enough in some cases to address the problem. Next slide, please. So finally, what are we doing specifically? And now in Greystone, let me end here. One of the things that I'm proud to talk about today is what we're calling the MASS project. And that stands for Making Any Space Smart project. Make any space smart. So I know some of you in your mind think, oh, this is great, Chris, but it's only the rich and famous that are going to be able to handle this. And that was a challenge for a while, but now as everything goes, especially technology, the more widespread it is, the prices fall down. We believe that we can make not only the home, but any environment in which a person might be, even if they're homeless on the street. We can make it smart through a subset of technology approaches that will then enable anyone to be connected to the people, to any other person, information or resources they need to become healthy or stay well anytime, anywhere. And our goal is to be able to do it for less than $500. And at that level, you can scale it to anyone, anywhere in the country, rural or urban. Next slide, please. So is it really impossible? Well, maybe if you consider some of these statistics, you might change your mind. 97% of all households have a television. We often don't think about televisions when we talk about this world. 96.1% of households below the poverty line have a TV. 95% of households have a TV or broadband connection. 92% of individuals own a cell phone, and 81% of households below the poverty line have cell phones. So with this information, we can connect to almost everybody, not absolutely everybody, but that overwhelming vast majority of people through technologies they already have. Don't even need to buy new ones. Technologies they already have. For a $20 investment, a $30 investment, you can change almost any dumb TV into a smart TV. Next slide, please. So, is it impossible? My response is everything is impossible until the first person does it. Thank you.
Dr.
Back
Gibbons.
to you. Go ahead, sorry.
Thank you, Dr. Gibbons. You have the same energy and enthusiasm I have always associated with endeavors you've taken on. I would remind our audience and the participants here that if you would fill in the Q&A at the bottom, if you have a question, we have time now for one or two. While I'm waiting to see if there's a question yet or if that would come later, Dr. Gibbons, I'd like to ask you about your personal journey. You began as a neurosurgical resident and you concluded your medical training getting a master's in public health and focusing on preventive medicine, and you were instrumental in Johns Hopkins Urban Initiative. I think that gives almost the full spectrum of healthcare. What pulled you from the highly technical N of one surgeon approach to looking for points of leverage? How do you help others people see why that part of the spectrum might be at least as important as where you began?
Oh man, Alan, it's a great question. Let me say, first of all, that I believe these problems are not problems that are going to be solved by one person or one type of person. We need all kinds of people. And while the things that I talked about today, most of them, although I are not the same, like say a surgeon's perspective. But what I didn't talk about today is, you can use the same technology in a future world that's not too far away for me, say as a surgeon in a hospital, to do surgery on somebody in their own home or halfway across the world, right? So I could have brought that aspect in, but I didn't for sake of time. But let me say there were a number of factors while that brought me to this place. I have to speak for myself candidly. I'm a man of faith, and so I believe that God had something to do with this. And I don't shy away from that. You may disagree with me, but that was a big part of it. Another part of it was, as I went down the road, I began seeing, I've always had this interest and involvement at the community level, but obviously during training and surgery, that gets put to the side because you simply don't have time for those kinds of things. And that really began to bother me on one side. On the other side, many of the things that we were treating in the emergency rooms and the emergencies that would come in, like the community health worker that I had, who was 50 something years old and had been strung. He was clean then, but he had been strung out on drugs for 30 or 40 or 50 years. I mean, for every one that got clean after 50 years, there's 100 more that don't get clean ever. And I was seeing these guys 50, 60, 70 years old, still strung out on drugs, cleaning out their abscesses and other things. And it just was feeling like a revolving wheel. Yeah, I'm doing something good. Yeah, I'm getting paid, but the problems aren't changing out there. We've got to do something more. And so for a long series of events, I finally made a shift. And then some other events came and brought me to the idea that maybe I came to this realization early that whatever the answer is, it's not like I had the answer, but I knew it wasn't going to be doing the same thing everybody else was doing, because that wasn't working. And then through another series of events, came to the realization that maybe technology might be something that could allow us to do something we hadn't been done before. But this was 20 plus years ago, long before technology was even a thing in healthcare. And I even got criticized by one of my department chairs at Hopkins. He told me, you're a bright young kid, you're going to do well here, but you got to let this technology thing go. It's not going anywhere in healthcare. So obviously things changed, and here we are. But in a nutshell, that's kind of what it was.
So Chris, if two things. One briefly with a question from our participants, and another I want to put a pin in for after our other presenters. The one for afterwards is, how do we navigate the privacy issues with smart technology, HIPAA, for example. So I'll leave that there so you and our other presenters could be thinking about that. But the one for you, since you mentioned it, and you and I are friends, I know the role that your faith has played in your life and continues to play. The question from our participant is, Dr. Gibbons, how do you see the role of the faith community in healthcare delivery and addressing these healthcare inequities?
Yeah, I think it's tremendously important, tremendously important. I didn't talk about that today, but in other talks, I've talked about it quite a bit. I think there are many ways that science as a whole has has, whether intentionally or unintentionally, and you can debate whether that is, but they have sort of, subjugated or pushed to the side the role of faith. And we're beginning to come back to it, but not from a real, what I would articulate as a perspective of real value, but one, okay, if the patients do it, it's important to them largely. But you know that there have been studies, for example, that show, and there are people criticizing the studies, but there have been studies that have been, first of all, let me say, there are no studies where you'll find nobody criticizing them, all right? So let's just put the context in place. So criticism doesn't mean anything other than criticism. But University of Baltimore was involved, or University of Maryland at Baltimore was involved in, I think you know these studies, Alan, years ago, studies where they had a group of people who were in the intensive care unit and a group of people who were not in the intensive care unit. And then they had a group of people praying for each one of these groups. Now, the people in the units didn't know anything about it, but they prayed for them for a period of time and then looked at their outcomes. And in that study, they found differences in the group of people who were prayed for. There are other studies that didn't show something like that. So you can choose, if you want to choose just based on the science, which you want to believe. For me, I start from faith, so I believe those kinds of things. But there are other things. Let me give you one other example. So as a physician, I was taught in medical school that certain populations, are more religious, more this, and because some people will tell the doctor, doc, I agree with what you want to do, but I believe God is going to take care of that. They taught me to understand and interpret that reaction with a term that's used. It's called fatalism. Right. And I accepted that. But as I got older and began to think about this thing, I said, wait a minute, we're actually turning what people believe in and calling it a pejorative term. We're actually saying, okay, take them into account because they're not dealing in real science. They're fatalistic. Now, it's one thing, okay, the doctor may not believe the same way as the patient. That's fine. But I believe now it's inappropriate for us as scientists in science, just because we believe differently on matters of faith, to denigrate, somebody else's faith on that matter. So I'm wholly against, those kinds of things. The other, one last example, since you asked, I remember I trained obviously in surgery and even in I think it was in medical school, learning how to do transplantation and liver transplants and kidney transplants and things like that. These are long surgeries, and the patients afterwards have to have many, many, many medications. And I remember the senior doctors talking to us as medical students and residents and telling us, when you're trying to make decisions about who's a qualified candidate for an operation, we don't have enough organs to go around to people, so we don't want to waste them. So if you have an African-American family, you might not give it to them not because they're not valued, but they may not have the family supports together that might enable them to get back to the hospital when they need to get back to the hospital, or take all the different complicated regimens of medicines that they got to take when it's needed. And again, I accepted that at first as good advice, but then as I got older, I was like, wait a minute. I know some about African-American families. They may not have a lot of things. They may not have a lot of money, but one thing they got is a lot of family, right? They got a lot of family support. And so while I believe that person may have been well-meaning and well-intentioned, at its core, that thinking, I think, is biased and inappropriate. And so these are some examples where, things can come into play, sometimes unconsciously, but I think faith can have a tremendous role to play in going forward.
Thank you so much, Dr. Gibbons. And I'd like to say that my own view, no empirical studies, is that sustainable change begins at the bottom and works its way up. And I think the long and lasting friendship and mutual respect that Dr. Gibbons and I have is an example of that. And how we can then go forth in the world and work together on some of these issues. Thank you,
Absolutely.
sir.
Thank you.
Mr. Brown, I'm hopeful that in discussing hurdle, you'll be able to identify within the context of what we've just heard from Dr. Gibbons, how business is meeting a need and has the possibility for being sustainable and reducing inequities. I know that when we started our conversation yesterday, I had only the awareness of the match with cultural appropriateness for needs for mental health care. And you said, well, that's where we began, but we've grown beyond that now. Could you lead us through that, Mr. Brown?
Definitely. Thank you, Alan. Well, I'd first like to say, Hurdle Health is really bringing together the best of in-person therapy and technology to deliver a culturally intentional teletherapy platform for people of color and other minorities. And Hurdle was really born out of our CEO, Kevin Dedner's experience with going to therapy. Kevin had several different failed attempts with a therapist, with multiple therapists. He connected with one therapist and, he reached out to that therapist and said, hey, why was I able to connect with you? And that therapist said, just by the questioning, the conversation we were having, and Kevin said, yeah, but there was something different. It was almost like you knew how to relate to me. And what happened was, what you found out was that that therapist had been trained in cultural humility and responsiveness. And from there, Hurdle was born. We understand that, minorities are less than half as likely to receive mental health services as other folks. If you look at stigma, cost, wait times have really kept folks from seeking therapy. And then if they did seek therapy, they weren't connecting with their therapist. So we really launched with the mission to tackle these barriers through these invisible barriers, I should say, through technology, offering a culturally led teletherapy platform. And we're able to do so by, again, training our therapists in cultural humility as well as responsiveness. We know that less than 4% of therapists in the United States are people of color. So what does that mean? That we need to train other therapists outside of the BIPOC community and minorities in this cultural responsiveness as well as humility. If you think about our own interactions, we connect with people that understand us. We open up more to people that understand us. With that being said, corporate America, because we do work with enterprise clients as well as payers, they are now reaching out to us. They understand, that something has to be done for their employees. They're hearing it from their employees that, one, there's a lack of therapists. Two, if they do connect with a therapist, it's not the right therapist for them. And there's been a lot of racial unrest in the world. We know that. Since George Floyd, there's been tons of racial unrest. And employers are really wanting to offer a solution to their members. But what we're finding out is that in our conversations with prospects and our clients is that they want to offer Hurdle to all their members, not just people of color, not just minorities, because that cultural responsiveness and humility goes across the board. Yes, we started out working primarily with men of color. Then we migrated to BIPOC community. Now we've kind of migrated to BIPOC and other minorities. And as I mentioned, enterprise clients, your Fortune 500s are reaching out to us wanting to offer Hurdle to all of their members, which is totally fine. What we're seeing across our book of business is that members are staying with their therapists. We're seeing 2 to 3 times the historical average, which means that humility and that responsiveness is connecting with therapists and their members are connected. They're understanding one another. If you look traditionally, only about 50% of minorities complete therapy, which is unheard of. And couple that with the fact that we're seeing 2 to 3 times the historical average means that our training is working. Mm-hmm. It's gone a long way. We continue to evolve. But again, Hurdle was born out of our CEO's experiences with not feeling like he was connecting with his therapist. Therefore, when he did connect with that therapist, again, he went back, had conversations with that therapist to find out, what was happening. Why were you able to connect with me? And we're hearing it across our clients that, their members are getting the help that they need. One of the things that we talked about recently at work was that we're seeing 4.75 satisfaction on a 5-point scale. So we're reaching members. people are completing therapy again. And it's all goes back to that humility and that responsiveness. As I mentioned, we started out for men of color. We have therapists across all different nationalities, ethnicities. We have members that are using our platform as well across the board. So just really meeting people where they are on their personal journey goes a long way.
Mr. Brown, the questions that we have, I like to hold those for the end because I think they span several of the presentations. But I would ask you, when you start a business, whether it's healthcare or not, any business, the likelihood of still being in business in a year or in 5 years is not high. And when you start when Mr. Dedner started his business and that you're vice president of now, what are the key lessons learned? And if you could somehow tie that to the topic that we're working with today, using innovation, technology, and entrepreneurship to address healthcare inequities, what are the lessons you've learned?
I think one thing with Hurdle is that, there was a need for Hurdle in the market. As I mentioned, people of color traditionally do not seek therapy. It's almost unheard of to really talk about going to see a therapist. Yeah. The fact that Kevin was able to bring together, technology and in-person therapy together to combine Hurdle, it goes back to a comfort level 1 of the therapist, but then 2, also comfort level of being in your home, being in your car, being at work, having those relationships, conversations with your therapist, one through the app, as well as over the telephone, really lends to folks completing therapy. So it goes back really just having that comfort level, feeling comfortable. I will tell you this as well, it was eye-opening for me to come to Hurdle after being at one of the competitors and kind of seeing underneath the hood some and having those conversations with a lot of the VCs, investors that are reaching out to us, is that folks understand the need for Hurdle. They understand how important it is to offer therapy to folks that normally wouldn't get therapy. And I think the marriage of technology and that really in-person, the culture of humility, responsiveness is going a long way with our solution.
That's a wonderful explanation. I would like to leave it general and open, but if you would be receptive to it, we have some faculty at our university who have interests that are particularly in the areas in which the space in which Hurdle works and is growing. So at some point, if you were interested in some sort of collaborative discussions, publications, or research, we could facilitate that.
Definitely, we would welcome that opportunity.
Thank you, Mr. Brown. What I'd like to do now is move forward to our next speaker, Dr. Yahya Shaikh. Dr. Shaikh has a rich history. You will notice that there is a theme in today's webinar, and that theme is Johns Hopkins, not exclusively, but there are at least 3 of us who have JH on their resume. So Dr. Shaikh, if you would be so kind as to take over now.
Thank you so much, Alan. Thank you so much to the speakers and the dean and the audience for attending. There's so many different places we can take this, and I think what I want to do is maybe make this a little bit more practical, give you guys some tools that when we think about innovation and reducing healthcare inequities, we might be able to walk away with something. So when we think about healthcare innovation, right, there's a couple of things that come to mind. I mean, I work with a lot of startups. A lot of folks in the audience might be intending to do a startup, or you might know somebody that you're advising who's doing a startup. So when we look at, for example, diabetes apps, there's some data that I was looking at recently where about in 2020, like right before the pandemic, like $800 million were raised just for diabetes care. That's for diagnoses, management, diabetes prevention programs, a lot of different applications. And one of the things that struck me is, as Dr. Gibbons was correctly pointing out, there is a lack of innovation happening for communities, for themselves. So there is this idea that there's communities that are innovating for the other, but the others are not innovating for themselves. And I want to take that idea and I want to push it, I want to expand it a little bit more. Because when we think about disease and we think about inequities and we think about disparities, there's certain thoughts that come to mind, right? So one is there's data that comes out from the CDC that looked at mortality. Well, even before then, when we think about the top 10 causes of mortality, we think about cardiovascular disease, we think about cancer, we think about homicide and injuries, a number of different conditions. When we look at, there's some studies that have looked at the social factors that are related to mortality. And when you look at that, you actually find that mortality related to social factors like low education is actually more than deaths caused by lung cancer, colorectal cancer, breast cancer combined. And these three cancers are the leading cause of death within cancers, which is the number 2 cause of mortality in the US. So when we think about what is really driving disease, and what is really driving deaths, then we do have to take a step back and we have to wonder whether innovating just for the clinical environment is really where it's at. So that's number 1. Number 2 is that, when the kind of innovation that we do, the solution that we come up with is oftentimes going to be informed by the questions that we ask. If you ask a particular question, it's going to lead us down a path that's going to lead to a solution that will be very different than a solution for the same space if you were to ask it differently, right? And one of the reasons this thought process is the type of questions you ask is important is because when we look at how diabetes occurs in the US, and when we're talking about marginalized communities, right? Or when we look at how chronic disease or mortality occurs in the US, it's not a random distribution. It's just spread out randomly affecting people. When you actually visualize it on a map, what we see is you have very discrete clusters. There's one cluster that's now known as the diabetes belt. But 20 years ago, it was known as the stroke and cardiovascular disease belt. 80 years ago, that same region, cutting down the Appalachian Mountains, the Appalachian region and going across the south, was known as the measles belt, the very same region. So the question is why? What's going on? Well, when you look at what's happening, and we think back to the social factors, well, the entire bottom part, the south, and going up the Mississippi River Delta, that's where slavery happened. That's where cotton was a driver of economy. Human labor, enslaved labor, drove those costs of harvesting down, and that led to a certain group of people, African Americans, being disenfranchised, right? But then that led, after emancipation, that then led to sharecropping, that led to segregation, it led to redlining, it led to discrimination, a whole set of other things that then informed how social determinants of health are distributed, and that then informs how health outcomes are distributed. You look at Native nations, right? They're distributed all across the US, but there are things that tie them together, the trauma that they experienced in the past. So for example, if you look at the Dene Nation, the Navajo Nation, one of the largest in the US, 40% of the population doesn't have running water. 40%. The Pima Nation, also in that same area, region as Arizona, is one of the most well-studied populations in the world in public health. And the reason is because they have the highest rate of diabetes, not in the US, but in the world. About 50% of them, of the Pima Indians have diabetes. Why is that the case? Their diabetes they're known in their own language as the river people, and their diabetes start to increase after the 1950s, and it just start skyrocketing. Why is that the case? Well, the systems that were set up around them was different. You look at Lakota Nation up by the Dakotas, right? There, where Wounded Knee Massacre happened. Well, that's exactly where the 3 poorest counties in the U.S. are all there. The Pine Ridge Reservation, the 3 poorest counties, the per capita income there is lower. The annual per capita income there is lower than what one of us would probably earn within a single month, right? So now when we think about disease, it's not just about the clinical diagnosis or management or treatment. We need to expand this. We need to think about the system itself. The questions that we ask are going to be different based on the communities that we come and the realities that are shaping our environment, right? So the systems that we see around us are what dictate our outcomes. But then when we start thinking about healthcare disparities from inequities from that perspective, then things start to take a different shape as well when we consider innovation. And the reason that takes on a different shape is because you have to ask this question, that if systems are determining health outcomes, might there not be similar systems that are determining innovation outcomes, right? Mm. Because their innovation, imagine this, okay? Imagine this. There's a saying in Swahili, which is that you can't leave you can't cross an ocean without leaving the shore, right? I mean, it's in many different cultures. This very similar, it's this interesting similarity between many different cultures. But then this idea is, what if your ocean is a river that somebody points in a particular direction and they say innovate in this paradigm, in this environment? If your innovation environment is dictated to you by somebody else, or by the environment, or by systems, or a historic artifact, then you could innovate all you want, right? But you're boxed in by a particular paradigm, particular framework that has been developed not to advantage you, but then to advantage other groups, sometimes at the disadvantage to you, right? So then how do we break out of this? Because we were talking about tools, right? How do we break out of this? The tool for innovation, and Chris mentioned this earlier, it has to start with innovative thinking. But innovative thinking can't happen within parameters that have been set by others, right? So how do we break out of that? So in many different, I do a lot of research. Chris, we're all academics here. We do a lot of research, and one of the major paradigms in research now is decolonizing research and decolonizing knowledge systems, right? And that's exactly what we need in innovation as well, decolonizing innovation, right? But what does that mean? Like, how do we decolonize innovation? Let me give an example. I was in Uganda recently, and it's amazing. When I want to send money to somebody else, all I have to do is pick out my iPhone, or I can pick out a dumb phone actually, and text a number, right? And that number will then simply lead me to a menu that will ask, who do you want to send money to? I put in that person's number, and how much do you want to send? I put in that amount, press send, and it's done. We don't have that here. Why don't we have that here? Because their system is different. Their paradigm of innovation, what they're working with, is completely different, right? Or when we think about AI, okay? So when we're thinking about artificial intelligence, there's a number of questions that we need to ask. One of the questions is, whose intelligence are we artificializing when we say artificial intelligence, right? But then even when we look at the paradigm of how artificial intelligence is conceived of, and we think about the sci-fi or the visions that people have, it's about artificial intelligence perhaps at some point taking on a consciousness, taking on an identity, becoming something, right? But what if the idea of intelligence is not about your mind, your brain is not necessarily your identity, but what if the paradigm of intelligence is that your brain is a tool that your soul uses to interpret the world, right? Now, all of a sudden, artificial intelligence is not some entity that can be perhaps maleficent that's out there, but it's something that we can use as a human being, as the human species, to bring something else to the world, right? It's a tool, but not taking on an identity of its own. It's an extension of what we have as a tool, right? Or if we think about other models, so for example, when we think about indigenous communities around the world, they have a very particular way of approaching industry, a very particular way of approaching economy, right? And many indigenous worldviews are based on being biocentric versus human-centric, right? Human-centric means that what can I do in this environment to benefit myself, right? So how do I best exploit the coal mines in the Appalachian region, blow up the mountaintops so that I can make money, so I can get rich. Now people do that, and you have an extractive economic exploitation of the Appalachian region, and the levels of cancer there, lung cancer, et cetera, but cancer there in those counties are twice as high as the surrounding counties, and 3 times cancer mortality there is 3 times as high as anywhere else. but that human-centric approach benefits the individual. Now imagine a biocentric approach where your goal is not to benefit you, but you understand you're part of a family, and that family includes the earth, it includes the water, it includes the animals, it includes the sky, it includes the earth, right? Now, all of a sudden, your role and your reason for existence is all of a sudden different. When you have that worldview, and then you ask questions, right? How do I develop technology? What does success mean for me, so that the kind of question I ask to benefit myself can benefit other things? What are the problems that I see from my biocentric perspective, from an indigenous worldview perspective, that might be missing, that might not even occur to me if I were to think about it from a human-centric perspective, right? And then when we think about pain points, you go to any investor and you pitch your product, first thing they're gonna ask you is, what's the pain point you're solving for, right? And if your pain point is driven by human-centric approaches, then you're going to be leading innovation in a certain way, which means though that your paradigm in which you innovate, your river, the banks are parameterized for you by somebody else. But all of a sudden, when you break that apart and you go to a different paradigm of thought, right? Whether it's indigenous, whether it's sub-Saharan African, whether it's Asian, whatever it might be, right? You go back to a different paradigm of thought, and then you come back to your environment, the questions and the innovations, the technology and the goals that you have are going to be so far beyond what other people do. You're going to be leapfrogging like the way they did, for example, in sub-Saharan African countries. Many of them have an integrated financial system with their connectivity, right? So the point here is that, you know, when we think about innovation and reducing healthcare disparities, the first thing we need to think about is inequities in innovation itself, and not just the inclusion in the process of innovation, if that process of innovation is happening within boundaries that have been dictated by others. Now you have to go beyond those boundaries, decolonize our own thought process for innovation. There are a couple of other things that I wanted to mention, but let me stop here. And I don't know if I'm going over time, Alan, but let me stop here and give the mic back to you.
Well, thank you. I think you've brought another perspective that's critical. And often if you see leaps or breakthroughs, it's because there is a person who can see the same things others see, but they also see other possibilities that they don't see. Listening to you, I was reminded of the work of Naval Ravikant, whom you probably know, or Paul Graham, who founder of Y Combinator. And if I think of Paul Graham and Y Combinator, someone like that, and the boot camps and the way in which they have accelerators for businesses, it seems that if there's a marriage between the vision that you were talking about and that Dr. Gibbons had mentioned, and we see an example of this with what Mr. Brown was talking about, if that could start to be at least a level of awareness within the companies that they encourage and that come out of there. And these are not small companies. Dropbox came out of there. Airbnb came out of there. These are substantial opportunities. So one of the things I like to do is think about how we can use our position of voice to be connectors. And even though it's not in a hierarchical and a command and control way of influencing the direction of events, we can, through making those connections and harnessing the ideas enough to get them into the right spaces. An example like today. So I want to thank you very much for that. And if you could briefly on one other piece, one of the questions we have, I have to, this is edited for concision for the time we have. It discusses the role and the context in which we humans find ourselves and the socioeconomic differences. People look at me and they hear how I speak and they think a certain thing. They're wrong on at least 95% of it. So, and I don't need to be like TMI with this, but I'm just saying we all have the origins and we have expectations. So the question that was asked, what changes if we look at incarceration, predictors of crime, recidivism, and even healthcare, the nexus of that? What kinds of changes do we need to see in the criminal justice system in order to create a healthier population? And how might universities like University of Baltimore and our college that Dean Hartley is dean of, where we focus on engagement, civic engagement. If we take the ideas that you have and notice that some of these disparities are not just health disparities, but they might just predispose to this cycling in criminal justice. What would you say to that attendee?
Yeah, so I think there's a lot that can be said. First of all, the idea of criminal justice, one of the things that we need to keep in mind is definitions, right? Like who defines what a crime is, determines who becomes a criminal, right? And then who becomes a criminal determines whether the person actually gets justice or not. In many instances, it's an oxymoron to say criminal justice. But let me give you a really quick example. So way back in the days, there was a heroin epidemic, and it used to hurt inner city African-American communities a lot. But at that time, during those days, it was looked at as a criminal activity. It was thought about as, get tough on drugs. So that was the kind of intervention that was done.
Right.
It was framed in a way that it was a criminal enterprise that needed to be intervened on by the justice system. But much of that is because the way that those activities were being defined was done by people whose families were not experiencing addiction or substance abuse disorders, et cetera, at least in their immediate consciousness. Fast forward decades later, all of a sudden we have the current Secretary General of Health, Dr. Murthy. In the previous administration, Obama's administration, he went up and called it a public health crisis. What changed? It's still the exact same addiction. It's still the exact same activity. What changed was that the populations that were being hit by this addiction all of a sudden look more like the representatives that we have in Senate and Congress that can then make and push these kind of paradigms. All of a sudden it's hitting home, and all of a sudden you're like, okay, well, my uncle is not a bad guy. He couldn't be a criminal. This must be some kind of a health issue, right? So now it's a public health crisis. The same thing, happens in many different instances. But this idea of what is a crime, what is a criminal, where I know when something it's no longer a crime, it's a public health issue. Who benefits still from it? One other example: marijuana, right? Cannabis was being sold for quite a while, right? And it was a criminal enterprise. Now, when it's legalized in many communities, who benefits from those licenses? I'm in Baltimore, right? And in Baltimore, in Maryland, you can see, we're all in Baltimore, where you can see that those licenses and that license, when it's legalized, those licenses, there's disparities in who gets the licenses, just like there was disparities who was locked up when it was illegal, right? So in my opinion, one of the first things we need to understand is that who defines a crime, who defines a criminal, and what is a criminal, and the consequences of that is really dependent on who's driving these definitions. There's a lot more to be said about the criminal justice system, but then the other thing to keep in mind is that many folks have referred to this as the new Jim Crow. And it is a way of segregation. It is a way of marking African-American and other communities in order to fund a certain type of economy, and then continue ongoing enterprises in a way that doesn't advantage their communities. So there's a lot more that can be said, but maybe I'll stop there and give others a chance.
Well, I appreciate that. And in order to group the discussion at the end, what I'd like to do is transition to our final speaker. And thank you, Dr. Shaikh. So our next speaker is a doctoral student at the University of Baltimore in public administration. Ms. Anna Castillo-Nye is also an outreach person for Lutherville Pharmacy, which has 2 pharmacies. And I would like to start with an anecdote of how I had the scales removed from my eyes. I went to pharmacy school as an older adult. I was 27. I know it's not old, but it was older. And my aim was drug delivery systems and to get a PhD in pharmaceutical chemistry. I was particularly interested in anti-neoplastics and targeting those. And I did well academically. And yet the experience caused me to change the way I saw what needed to be done in the world, in a way like what Dr. Gibbons had described. I was at the counter in a community, and a woman came with her child, and presented a prescription. It was for an over-the-counter product. It wasn't a prescription product. And it was in a public program. And I explained to her that she'd have to pay for it, that it's not covered by that particular program. And she said, I don't have any money. I took the bottle and I literally turned it around. I pointed to the price sticker. I said, this is what it costs the pharmacy. I don't own the pharmacy. If you pay this, I'll give it to you. I can't give it away. She said, I don't have it. I guess they'll pay when he goes in the hospital. And I thought, something's wrong here. And what we need solutions to isn't the next drug delivery system. And so my master's is in public health and my doctorate's from the School of Public Health. I have great respect for pharmacy and being on the front lines because of the complexity with what you address, because it's the interface and it presents to you. What Ms. Castillo-Nye is doing is actually taking charge of that and doing outreach. So going beyond what are the random things that present and occur. So Ms. Castillo-Nye, if you would take over now.
Thank you, everybody. And I'm going to attempt to share my screen. Bear with me. I am the worst millennial. Let me figure out how to do this. Okay.
And I want to thank everyone who came before you, because so far, this has been a coherent webinar in even better ways than I had anticipated when I was thinking about subject matter. It's the people, as always, who make it what it is. Thank you, Anna.
Thank you. Okay. Can everybody see that part of the screen? Perfect.
Yes.
All right, everybody. Ooh, I feel like I'm following some tough acts today. But I'm gonna do my best, and I'm certainly I think probably the most analog and potentially the smallest operation coming out of here. But I'm going to show you and demonstrate to you today why that's actually going to be really key to some of the work that we want to do. So again, my name is Anna. I am Director for Development and Community Partnerships at the pharmacy that my husband and I own here in Baltimore County. So we are an independent pharmacy, family owns. By the nature of small business, I wear a lot of hats. And so my roles are really split between management and operations and doing some of these then public facing events like these, working with chambers of commerce, our nonprofit groups and our patient advocacy groups as well. And what I'm hoping to do for you all today is to showcase very briefly, not only some of the work that we do at the pharmacy, but particularly how our vision for the space that independent pharmacy can occupy now and in the future in addressing some of these health equity issues. I truly believe this is an area of untapped potential, and I'm hoping that by the end of my segment today, you'll believe so too. So to begin, I want to show you what is often the reaction when I tell folks about working in independent pharmacy. Okay, and that is the caveat being, the reaction I get depends on geography. Okay, it's going to depend on generations. If you look at places like Mississippi, West Virginia, anywhere that has lots of large swaths of isolated rural areas, they depend much more wholly on independent pharmacies than your CVS and your Walgreens. And with those notable exceptions, the majority of people really turn to these big chain stores, either out of convenience or just because they don't know that we exist still. And I believe, and it's our belief that, and I hope this is a fairly non-controversial statement, that there are roles for large, far-reaching corporations that they play, and then there are also roles for the little guy like us. And it's this idea of size and scale that I think is going to be key for you to keep in mind during my talk today. So let's give some context to this. Okay. So this is now according to the latest digest, which is published by the National Community Pharmacy Association. So as of 2021, there are about 19,397 independent pharmacies that are still operating in the United States. That's roughly, a third of all retail pharmacies that exist. For context, CVS and Walgreens are operating at around 9,000 stores each. That's not including hospitals, okay? And they've taken over a lot of the in-house pharmacies and hospitals and long-term care facilities. 95% of those identify primarily as retail, and then you've got folks in long-term care, compounding, and the like. So, and then of course, you know, over half of those prescriptions are coming in as Part D and Medicaid, which is fill in a lot of these populations that we're going to be talking about in terms of health inequity. So what is it that we do exactly, right? You ask that to sort of the layman on the street and you get the most ungenerous, very glib answer, right? This is what we get. You are a pill counter, and in maybe even less generous terms, we get called pill pushers. And so what I want to do with this idea a little bit is certainly unpack that. Yes, is that a part of our daily operations? Absolutely. But we are much more than that. And something that Dr. Gibbons had alluded to in his presentation, in particular with COVID. Pharmacies play a role in continuity of care, right? Continuity of care. We close the loop in a lot of spaces. When you leave your doctor's appointment, when you are discharged from the hospital, oftentimes your pharmacist is the last person that you see before you go home. And all care from that point on, has the point of stopping there. If the issues with your prescriptions are not taken care of. They're frontline in many aspects in confronting the opioid epidemic, because obviously this is where these things are getting dispensed. And the responsibility of the pharmacy and the pharmacy staff in managing that as those frontliners. And then finally, pharmacies being these key government partners, in particular for vaccination efforts in the last couple of years. This is going to be news to some of you. For others, and particularly all of our clinicians that are on right now, you have friends that are pharmacists and you know the work that they do to sort of work with their communities. So what I'm trying to argue today is that everything that we do at our pharmacy and many of our colleague pharmacies that are independents are really falling into two different categories, okay? What we like to call lowercase p problem solving, uppercase p problem solving. And to be clear, when I say lowercase p, I don't necessarily mean that's because they're less important, but rather they're the most daily common things that we deal with, right? And I don't think that these smaller organizations get enough credit for this. And what I want to demonstrate today is how the way that we work at these smaller p problem solving levels is what feeds into the bigger public health problems. Right, so this is the question that I want to pose, right? So what is the context for which independent pharmacy acts as a nexus of care? I talked about that a little bit in terms of our examples of continuity of care, but really when I'm thinking about standing in front of a patient every day at the street level, 99% of the problems that we confront are about how we navigate this kind of impossibly complicated health system that we have in the country. And I'm a doctoral student in the DPA program, and it always is really interesting when our international classmates come in and we start talking about healthcare, and they are just so confused about why, as a country, we haven't yet grasped ideas of how to care for everybody and that everybody deserves, good health. So let's look at a couple of key examples. I won't dig into these too much, but what I think we need to remember about low-income vulnerable populations, those that historically have faced healthcare inequalities, is that so much of navigating the healthcare system is made more difficult because of your lack of resources, not just financial resources, but on your social capital, right, as well. And at the scale that we operate in, we are much more better positioned because of the size, because of the volume of patients, to really get at this at a minute level. And it's not just about good customer service. I think that it's a cliche in small business to say, oh, okay, small businesses is where you can go for better customer service, but it's not just about that as much as it is, what are the things that we do that make more sense because of our scale? Let's take this big one, right? So understanding your prescription insurance. You can be the most advanced sort of person in your company, person in your university. If I ask you for your BIN and your PCN number, you're going to stare me right in the face and be like, I don't know what that means, right? And to be honest with you, those tiny little plastic cards that you get at your, from the mail or from your insurance says, half the time those numbers aren't even correct, right? And so we're flipping through our wallets, we're going through that, we're calling numbers and trying to figure that out. Now imagine if you are a low income 78-year-old patient with dementia. You've got 22 prescriptions, you've got 7 different doctors, and nobody to act in what we call sort of that quarterback position, right? Who is the person that is going to see that 30,000 foot view, understanding of your health? And oftentimes that's us. And that was certainly the case during COVID, when doctors' offices and hospitals were inundated. Lots of smaller practices were still trying to figure out their telehealth. We were open. I feel like I've been awake since March of 2020. We were open and fielding a lot of these calls and trying to act. I've always believed that pharmacies have been a community hub, but I think it was made so in a very literal way during the pandemic. And so, how do we deal with those issues? When I talk about things like healthcare literacy, do you know what questions to ask? Do you know where to turn to get advice beyond, what are you using to treat your particular illness, but who do I get to help me pay for my copays? How do I navigate the system in which my social worker knows me, my doctor kind of knows me, but the person, that has to deal with you on the other side of the insurance line has no idea who you are and what you've been through, right? And so those are kinds of, those are the pieces of the puzzle that we are often putting together at the level every day, at the store. And not just us, obviously, there's hundreds of small pharmacies here in the state of Maryland. But when you look at the performance and the volume in comparison to these big chain stores, and it's not really their fault, right? I don't blame technicians and pharmacies that work for CVS and Walgreens because of long wait times and all of that. Just like everybody else, they're understaffed and they've got huge corporate quotas to make. But this is a space in which we can do better. So how do these things then feed into sort of the big P problems? What are the quote unquote big public health questions that we can start to explore by first working within a small space? Again, a couple of examples here. Again, all of my clinicians in the room, medication adherence is that sort of big looming monster, right? For chronic disease management. So that could be diabetes, a plethora of other things. The example that I want to use for you today is focusing on HIV. So in the state of Maryland, and these are according to the Maryland Department of Health, there are about 31,700 HIV patients in the state of Maryland. Roughly 10,000 of those are accounted for in the city, in Baltimore City alone. And just like a lot of other disease states, men, and for HIV in particular, gay and bisexual men of color are disproportionately impacted by that. And so what are the issues for that when you're looking at Medicaid patients who are paying $0 to $3 for their medicines, when you are, when they're getting their deliveries for free, when they've been on these medicines for a while, so the side effects are sort of minimal than when they first started? Why are these patients not yet adhering to their regimens? That is a larger interdisciplinary question. This is when the folks with the masters in public health come in to answer. This is not something that is owned by MDs, right? So how do we ask those questions, and how do we make it an interdisciplinary problem? These are the things in which we try to tackle with our partners in transitional housing, with our partners in homeless shelters, our nonprofit folks. You need a village, very, very literally, to tackle some of these. And I think what's important to keep in mind is that, yes, we're a small space, but we're talking about the reverberation of particular actions. The second example that I wanted to talk to you and for us really hits home, obviously for everybody here, is vaccines for the COVID-19 pandemic. Now, a forgotten population as we were trying to get everybody vaccinated was folks for whatever reason, mobility or transportation issues, were homebound and could not get to vaccine sites, right? And so Lutherville Pharmacy, with our sort of a really amazing partners at the Baltimore City Department of Health and the working group at Hopkins and the fire department and the National Guard, very, very small group of people, we were going out and doing homebound vaccines. And when I say we're going out, I am getting in my Honda CR-V and I am driving to somebody's house and we are vaccinating as many people as we can. And that, I think, is a really interesting area for a small private, entity to be involved in. A, because we already know a lot of these patients, and B, because while the larger institutions have to work at this big scale and look at the big problem solving that they have to do, that we, in a very natural way, act as an incubator for a program like this, right? Let's see. How am I doing on time, Dr. Lyles?
I think you have enough time, but I would say a little bit.
Okay, sure.
5 to 8 minutes would be good.
Okay. So I think I'm going to skip my last example. So this is kind of the thesis of what I'm trying to say here. When you are taking a look at a particular industry, let's say healthcare, what happens is that when it is dominated by large industries, you create a sense of alienation. And I think there's no better metaphor for that kind of alienation than when you call up CVS and you end up being on the phone for an hour. That is the perfect metaphor for alienation and feelings of abandonment, right? The examples that I have here today of little p problem solving, what we're doing here is really saying the tactics and the strategies that we use at that level are what feed into the bigger P problems of public health. Mm-hmm. The centrality of it, that 30,000 foot view, our ability to be able to make decisions for our patients, I think feeds into the flexibility we have as a whole. It feeds into the fact that we have the space to innovate, that we can go out to chambers of commerce, that we can have these nonprofit partners to think about these questions, right? What we do as a business and what I hope we represent as a business is this idea that we can help to negate that feeling of alienation a little bit. And again, you might think that these kinds of businesses aren't around anymore. We're 34% of all of the retail pharmacies in the country. Think about that. We don't not necessarily have a united front, but that doesn't mean that we don't, there isn't a space for that. And yeah, that is really sort of, what I'm driving home today is what we do as a small business, the scale that we do our work in, really creates this very natural incubation space. And at the street level, when we're talking about technological innovation, when we're talking about the, revolutionary new drugs, certainly has a place of importance. But when a person can't get their prescriptions, when they don't have a cell phone, when they can't get on a bus to get their sort of life-saving prescriptions, who are the folks that play a role in filling in those gaps? And I think that you can absolutely turn to the independent pharmacy community to do that because we're still here. But yeah, thank you.
Thank you so much. And I greatly appreciate the compliment that you've brought to what the other speakers have presented. I want to come back now to open it up to everyone. If you have additional comments to each other, but I'll offer as a focus the question we had earlier: how do we deal with privacy and HIPAA within the context of interconnectivity and innovation and technology, and still protect what might be agency and ownership? The way I see what we've done today, what you've done today, is that Dr. Gibbons has given a vision, and it's an umbrella that includes an expansive idea that's focused on what would it look like, how could we use what is available to us to address healthcare inequities. And then we saw for a particular opportunity, the way in which innovation and business startup can do this, and how becoming active has a feedback loop that then defines what you are becoming as you meet the needs that you maybe incompletely realized when you began that journey. With Dr. Shaikh, what we see is the mind itself. Just how do we see these things? I've often thought, I'm from the rural South, and my very low completed education, my extended family and earlier generations. And I've wondered, what world did they perceive? How could they understand the world? And they couldn't understand the world today. It's not that they didn't have the capacity. My father he was quite brilliant, but he didn't finish second grade. So I'm thinking about this and what you were saying, which I think is an important way for us to understand. It's not always what's obvious. It's not always working within the problem as it's defined. How do we see what is a greater reality or the underlying reality? And then finally, with what you've done, Ms. Castillo-Nye, you've reminded us that there are real frontline workers here who are doing meritorious things. And what I was thinking about is how this could connect with the others, with your co-presenters. With, for example, in North Carolina, there was about 25 years ago, a project called the Asheville Project. And this was based in community pharmacies and Mr. Brown is in Durham, I believe, so he knows North Carolina well, maybe Charlotte now. But so this project collected data. It was PBR, practice-based research. And until there were data that could show that things could be done differently, they weren't. And it took the vision and the faith to take action. And then once there was publication and dissemination, then you get this virtuous feedback loop that allowed greater professional scope of practice. So that's where I would like to leave it. I would ask you about the privacy issue, because too many times it seems that a legitimate question can be gate shutting, particularly in mental health, Mr. Brown, but we want this to be gate opening. So I'll just throw it out to whomever wants to take it first.
Well, I'll chip in, Ellen. I really appreciate the comments that you just made, because I absolutely agree with you. I think, maybe in some ways I had the toughest job, right? Because at least I took it to give a presentation that was both inspiring, catalytic, but covered a broad spectrum. And I tried to indicate both what we know and sort of what's needed, and what at the end of the day, and illustrate both technology is needed, both professionals of many types are needed, but grassroots individuals, and I would argue grassroots organizations, are also needed. And so while I've spent time personally in my career working with all of those levels, I'm now at some ways more focused on creating the systems that enable all of these players to work together to do what they do. So I'm in 100% agreement with everything that I've heard today, specifically on the issue of privacy and things. I think there's a couple of things to keep in mind. HIPAA, the law that we're all referring to here, was written. I mean, it's the only piece of legislation that it doesn't matter how many people you ask. If you ask 10 lawyers, they give you 11 versions of what it says, right? At the end of the day. But most of us act as if something is in it as a safety valve, even if it might not be in it, and there are plenty of examples of things that are actually not according to HIPAA that people do with privacy. I'm not trying to say we should do less, but what I am trying to say, it's important to remember that HIPAA was written in an age where there was no technology at all. There was no electronic, really, technology. Everything was paper and pencil. And now we're living in a different world. And that's was sort of undercurrent of what I was saying. Technology is not just a thing that aids us. It's a thing that changes our world, sometimes in very fundamental ways. And so what is necessary then to break through is this new kind of thinking that's not just added on to what we were doing, but realizing our new context or our new change and then going from there. So part of it for me is, it's hard to imagine how HIPAA, as in the minds of the original writers, applied to electronic data, because there was no such thing, right?
Mhm.
But at the same time, nobody's trying to argue that electronic data should be exempt from HIPAA. We're just, the complexity is we got to think it through more, and there are some new nuances that weren't conceived of and not spoken to well by HIPAA that we got to think about now. We got to figure it out. And they're hard and they're complex and they're thorny and they're difficult to talk about, but we're the country that put a man on the moon. We can do hard and complex things if we put our minds to them. And we can't do things that are relatively simple if we don't want to.
Thank you, sir. I would point out the perversity of how things evolved to what they weren't intended. So HIPAA began health insurance portability. It began as an act to assure that you could have health insurance as you moved across insurers. And there was this minor thing about privacy that suddenly became the tail that wagged the dog. If you think of ERISA, which was in the mid-1970s, it was to protect pensions. And then it had this perverse effect of exempting self-insured companies from state mandates, which might require coverage of what would otherwise be market failures. So for your colleagues, Dr. Shaikh, you were going to say something? Or?
Yeah, so just a couple of things of a practical nature when we think about privacy. Sometimes this idea of privacy can be a restriction on innovation, but I would ask us to, step out of the paradigm again, right? Because when we think about privacy, it's being defined within a certain boundaries and borders. So let me give an example. So I was in Malaysia a little ways back, and they have an indigenous community in Malaysia. It's a tribe that lives lives in the forest. So they're called Orang Asli. So meaning Orang means forest, Asli means people. Orangutan is it's like a forest person. But regardless, so this Orang Asli tribe, when they would come to the hospital, what would happen is their identity is a shared identity. So when one person comes, the whole clan actually comes with them into the hospital. So initially the folks at the hospital would be like, well, no, you guys all can't come in. This is just one person care. But then they quickly realized that, okay, no, for this particular community, it's a shared identity. And what happens to one person happens to everybody else. So what they would do is they would actually have a separate space. So they would accommodate that entire clan and entire tribe, participating in that care in some way. We have a very similar situation in our Native American tribes here. When you look at the indigenous, Navajo Nation, for example, where a grandmother might only speak the Dene language. But when she goes to the doctors, she's not communicating with the doctor at all. She doesn't want to talk to the doctor, but she will talk with her through her daughter-in-law or her daughter to the doctor, right? And she has that expectation that what is mine is also hers, right? The shared identity. So first of all, when we think about privacy, it has to be contextualized within which paradigm we're thinking about, and not be conscious not to impose that paradigm on all communities, because then it restricts the kind of innovation that you want to do. If you start from a different community, we could actually think about many, many different ways of how privacy might apply there. The other thing too is that the way that technological advancements are going right now, some of these questions about privacy might actually be moot. So for example, right now we're thinking about very, cloud computing, cloud servers, cloud data, et cetera, right? So it's a very centralized approach. But with 5G and the amount of data that's going to be coming in, there's no cloud, there's no server that's going to be able to port in all the data and store it without being overwhelmed. So computing is moving out into the edges again. So it used to be in the edges, came back to the center, and is going back to the edges again. So when we think about computing then in a very distributed fashion, then it's back into the community and it's not as vulnerable because the infrastructure is decentralized. But then the challenge to that is anything that we know as cryptography or hash encryptions, et cetera, is going to be a moot point once quantum computing comes in, because it can, crack anything. So, but the point here is that, privacy is in the eye of the beholder and the community. And when we think about the intersection of innovation and inequities and privacy, it really has to be tailored for the particular community in which we're conceiving of this.
Dr. Lyles, could I just add one thing? Because I think that's a critical point. I want to give a very concrete, specific example where this is not just a challenge for, nations in Africa living in the forest, but right here in the United States in urban and rural communities. So many years ago, I was involved in a large multi-center study, and we were studying African Americans and stroke. And, stroke is one of those diseases where African Americans get it earlier, die more often, do less well. And even if they survive, their survival is not as good as others. And we were studying various aspects of this. And one of the things that we tested, but we knew is that, academics often say, oh, education is at least part of the solution. And I'm not saying it isn't, but about 30 or so percent of people, African Americans, this was Baltimore, DC, there are a bunch of places around the country, confused symptoms of stroke with symptoms of heart attack. Okay, they got those mixed up. And we don't need to discuss what they are. But so here, and then they also, so the way you treat those two things are different. And just for the sake of time, stroke, the thing to do is get to the emergency room immediately, because you have a time window in which to take a certain medicine that can potentially help you. And if you take too long, you might not be able to get the help and do as well. And so we also found that, about 20% of African Americans who were not confused about the difference, actually, when they recognize they may be having a stroke or a family member may be having a stroke, delayed getting to the hospital or calling the ambulance because they wanted to talk to their significant other. It could have been a husband or a wife, but it could have been a pastor at a church. It could have been, the person in the community that they value, they respect. They were not confused about what was happening, and they still wanted to do that. It's a point that I've sort of made several times, this idea of who's making the decisions. In America, this rugged individualism is taken as the core standard, but that's just not the way every culture really is. We're forced to do it, but our natural inclinations are not there. But let me just give you the last piece of it. The researchers, matter of fact, I was brought onto this study specifically because the NIH said you need more expertise with people of color on the research side of the coin. So when I got on there and they saw this information and said, oh, well, these people who are delaying, we need to develop an educational intervention. I hear this a lot with literacy as well, but we need to develop an educational intervention to teach them to call right away. And I said, no, that's not the problem. They already know. They have a cultural way of making decisions that involves the people in their circles that they believe important, that they need to connect with too. I'm not denying they need to get to the emergency room, but you're misunderstanding why they're doing what they're doing, and the solution to force them to do something other than what is culturally natural to them is not going to work as well as you might think it could work. And if we understood what was happening with them and designed a solution that didn't work against that, but worked in collaboration, it would probably work a lot better. And that's happened right here in the Baltimore, DC area.
I don't know if
that poses problems to security. Who do you let know what's going on, and privacy of data? All those issues come into play in that whole thing. But that's why I brought it up. Sorry.
No, thank you. So before I go to you, Ms. Castillo-Nye, with Mr. Brown, I would like to give a short anecdote and then ask you with Hurdle how you experienced this. So I remember, I'm old enough to remember when billing for medical services was in its early days. And as a part of that, as it started to evolve a bit, there were physically separate systems for the Department of Psychiatry and everything else. So you had somatic and you had psychiatric, sent different bills out, and the different bills that went out for the psychiatric didn't even have Department of Psychiatry, et cetera. It was a very innocuous envelope. What that intimated in terms of integrated patient care was frightening. Over time, there were ways of addressing this, but that was initially a concern. And so I don't know if I'm looking at Hurdle, how would you say that in the origins of Hurdle, how you keep the culture of that origin and it not become a typical mental health substance abuse carve-out benefit firm?
Okay. First, I'd like to say that we all go through a HIPAA training, as well as there's no PHI that's stored within the app. In regards to your example of billing, so we charge our clients per employee per month. So we just get that they have 10,000 employees, we bill them for those 10,000 employees. So there's no data that shows that Michael Brown is using Hurdle Health. So they never know who's using it. They just know X amount of members are actually using the app. And I will say this as well, I think the big thing for us, because obviously, we work with a lot of carriers as well as a lot of financial institutions, as far as prospects, clients, for them, HIPAA's a given. HIPAA's given. It's more so on having SOC 2, having your high trust, really just making sure all your systems across the board are secure. 1, 2, if there is a breach, what are those policies and procedures? Who's the privacy officer? How quickly will we be notified? They're looking more so at the policies and procedures that we have in place in case there is a breach. So hopefully that answers your question.
It does. Thank you very much. Anna, do you have thoughts on this? Because I know in pharmacy, initially, as there started to be clinical services, it was a struggle to find a space where you could have a confidential conversation.
Certainly. And I think that's why you are starting to see in places like Walgreens and CVS, you begin to see, minute clinics. And it's interesting. So CVS is, I don't know if anybody's following the news, is they're closing something like 900 stores over the next 3 years, not just of the closing of their retail spaces, but specifically so that they can create new kinds of interactions with the community. And so they're going to be trying to put in more spaces for primary care, for example, right? So that it is truly becoming more of this community hub. I think where you saw that probably the most and where I think those private consultations, when we really had to start to confront those issues, is when pharmacies became your go-to for your vaccinations. When they were for flu and shingles and all of these sort of regular immunization schedules, you had to actually really start thinking, well, now we need a place for patient interaction in which we never used to have before. Typically, when you look at a space like ours, which is very physically, in a literal sense, very small, what's nice about what we can do is that we have the capacity to have private conversations that can be scheduled ahead, almost like calling your doctor's office, which is great. And so we can talk to patients in that way. Lots of independent pharmacies are quite a bit older than we are. And so that's a kind of a tougher ask of them sometimes. Right. But when it comes to patient privacy generally, what we have to think of with HIPAA is big view, how do we both make sure that we are following all of the regulations that HIPAA asks of us, but at the same time, make it so that somebody has, somebody is getting their medication, period, end of the day. And sometimes, the easiest thing to do that is going to be through a text message and through sometimes even email. Phone calls are still a very much regular thing, but when we want patient response, especially now, we found that text messages are the way to do it. Now, you have to have a software that has the right kinds of security and protections for that. But where HIPAA really comes to play with us is how do we manage that regulation while also making sure that it doesn't create these barriers so that care is actually delivered. That's the piece that we have to think about.
Got it.
So can I just add something real quick? I just want to mention something that I've heard from actually Dr. Gibbons before, and I think it's relevant to this conversation, that, when we think about health, right now the innovation is very much consumer driven and is driven by the Apples of this world, the Googles of this world, et cetera. And for them, it's what the consumer wants and demands that becomes primary. And the issues surrounding privacy and HIPAA, they are there, but they're there in the same way that Facebook manages social media posts or manages your privacy data, and they're still within their servers, but they don't compromise the innovation that that particular company does. But folks that come from the health environment, me included, we tend to think about HIPAA and privacy first, and paralyzes sometimes in terms of innovation. And I would just ask us to reconsider the equation and think of it from the Apples of this world's perspective rather than the Hopkins of this world.
Got it. So we have lost our dean, but you'll see in the communications that he is extending his gratitude for your contribution. I would be remiss if I did not acknowledge that these are difficult times for higher education financially. Our budget is zero for honoraria, so everyone is giving because they're committed to what they do and who they are. Before I sign off, I would like to do two things. One is, I guess, a little bit of shameless self-promotion, but we have another webinar coming on the 19th. And this one addresses, in some ways, it's related to what we were talking about today. The title is Diversity, Education, and Inclusion in Math Education, Aligning Pedagogy, Purposeful Technology, and Applications. We have one of the leading mathematicians in the United States who is African-American, and he said, in part in his New York Times interview, what it has been like to be the only one of. He worked at NSA, he was at an R1 university, which he left to go to Pomona College because he wanted to widen the pathway for STEM. He wanted to create experiences for people who thought, this is not for me, to find out this is exactly what speaks to my soul. So that's April 19th. I'll send you information on it. You might find it interesting. Actually, I think you would find it interesting. You might have time. So it's that way. I want to thank you again so much, the executive director for our School of Health and Human Services, the executive director for our School of Public and International Affairs. Were on our call today. You have voice and leverage now, and with the recording, my expectation is that's now going to be meta-tagged, discoverable, so useful to you, but also useful in our university to be repurposed. And in the spirit of reciprocity, if there's ever any way in which I could be of use in terms of talking or providing information, please don't hesitate. Again, thank you so much.
Thank you.
Thank you.